Hello student, we are starting our lecture on musculoskeletal system. The musculoskeletal system is, it includes bones, joints, muscles, tendons, ligaments, and bursa of the body. There are problems that are associated with these structures, and they common and affect all age groups. The problems with the musculoskeletal system are generally not life-threatening situation, but they have a significant effect on the activities of daily living and productivity. So this is really important. So we need to address when a patient comes in with musculoskeletal complaints. Next slide. In the very young, there are some differences when it comes to the system. The skeleton is composed mainly of cartilage, and therefore it's more pliable, and meaning that they have less chances of fractures and break. And because it's pliable, when they do fracture, it is what you see is something called green stick fracture. Next slide. And then you have the mature bone, which are more rigid, and they consist of collagen, calcium, and phosphates. And the rigid connective tissue, again, that consists of the collagen, which is like fiber, and a large amount of crystallized minerals, which includes the calcium and the phosphates. Next slide. So this illustration showed you the skeleton. There are 206 bones in the human skeleton. The hands, you see carpals, metacarpals, phalanges. In the foot, you see tarsals, metatarsals, and phalanges. And you see the skeleton, you see the skull, clavicle, the scapular, sternum, the ribs. You see in the ribs, the humerus, the vertebrae, ulnar, radius, sacrum, femur, patella, tibia, and fibula. Next slide. So here's a description of them again. You have the axial portion, which is the cranium, the vertebrae, and the ribs. You can see that in the illustration. And then you have the areas that are more perpendicular portions, such as the limbs, the shoulders, and the hips. Next slide. So pretty much an overview of the anatomy and physiology of the bone. It's very simple. Structure and function. The skeletal system made out of bone formation, and it's also maintenance and healing. Articular system, which are the joints and help with the movement. There are certain movements that are not permissible based on the joint type. The skeletal muscle system helps with contraction, tone, and action. So exercise, it's really important to avoid atrophy and contractures. So diffuse syndrome, when a client gets to the point where they're not able to ambulate, it becomes a real significant issue that we have to address. Next slide. So bone formation, you have osteogenic cells, osteoblast, osteocyte, and osteoclast. The osteogenic cells are the ones that undergo cell division, osteoblast, and osteoclast. And what you have with osteocytes are the bone cells, and osteoclast is the breakdown. So the blast and the cast is a constant maintenance of that to avoid osteoporosis. So in osteoporosis, we'll talk about that later, you'll see an increase in osteoclast, so the breakdown of the bone cells. So, in general, you need homeostasis to maintain the breaking down and forming of new cells. But when you have an increase in breakdown of bone cells, then that creates further problems. Next slide. So what you have is the maintenance and formation of bone. And like I said earlier, there's ossification, and then there's reabsorption. Formation, which usually is the process of osteoclast that breaks down the tissue. Like I said, formation can be affected by many things, such as your local stress that are on the bone, the intake of vitamin D, parathyroid hormone, calcitonin, and blood supply. All this can affect how well the bone forms, and other diseases as such. That calcium is needed, and without calcium is needed for the bone formation, and without enough vitamin D, calcium will not be absorbed. The parathyroid hormone, which is located under the thyroid gland, and that is responsible in helping formation of calcium as well. Adequate supply, blood supply, it's important for every body parts, including the bone. Without it, the bones will not form or reabsorb as they should. Next slide. So there are types of bones. You have bones that are long, example, the femur. You have bones that are short, example, the metacarpals. And then you have the flat ones, such as the sternum. And then you have the irregular bones, which are the vertebrae. Next slide. The spongy bones are bones that are located in the ends of the long bones and the center of the flat and irregular bones. And these can help, withstand forces that is applied in many different directions. Next slide. And you have the compact bone, which covers the spongy bone. It's about 80% of the bones are in this form. There's cylinder around a central marrow cavity and can withstand force predominantly in one direction. Next slide. This is just showing an example of the spongy bone and the compact bone. Next slide. So what are the function of bone? Very important function. Pretty much the bone support and protect the structure of the body, right? It provides attachment for muscles and tendons and alignments. It contains tissue in the central cavities, which aids in the formation of blood, and it assists in regulating calcium and phosphate concentration. So yes, the bone is going to help with the framework to support the movement, the shape, positioning, attachment, and so forth. So it's important to have for the bones to be healthy. Next slide. So now we're talking about characteristic of the joints. The joint contains a cavity that is filled with synovial fluid, and it helps, in facilitating movement. Ligaments hold the bone and the joint in the correct position, and it helps in articulation of the 2 points that meet. Next slide. So there's classification of joints that you may see here. Pretty much they have joints that are immovable. So the ones we can't move, those that are slightly movable. And then those are freely movable joint. Examples of the joints that are freely movable, such as your hip joints. That's really important. And your hinge, the diatheresis. So you have the hinge saddle or the pivot, or that helps with gliding. You have the joints that are not movable. They're kind of fibrous and they're very fixed. There's no movement associated with this joint. You can see that on the chart there. So it's important for you to know which joints move, because when you're doing range of motion, there's certain limitation on how to extend or flex, each of those possible joint. Next slide. Slide is furthermore just showing you the different types of diarthrial joints. It's also in your textbook. Next slide. The synovial joint, these are the ones like the knee joint. You see between the knee, there's a cartilage between the joint, right? Allow for movement, but limited, you can hyperextend it. And what you see is the synovial joint and has this cartilage, and this cartilage sometimes is worn out. And when it wears out, then we have different joint condition that we will talk about in a few minutes. So synovial fluid is there, and it's found in the joint capsule. It is formed by this synovial membrane, which lines the joint capsule. It also lubricates the cartilage and cushions it for shock. All right, next slide. So the knee joint, that's what I said as an example. It's a synovial joint that has cartilage and is a hinge joint. Next slide. So this is an anterior view of the major muscles. So you've seen the major muscles, quadriceps, vastus lateralis, and then you have rectus femoris. You have the bicep brachia, deltoid, transverse, external oblique. There's many different. So this is a view of the muscle, major muscles. Next slide. And this is showing you the posterior view of the major muscles. So you have the gluteus maximus, the butt muscle, and it's important, because there's certain conditions that actually affect, the muscles and which create weakness, and so we need to pay attention to that. Okay, next slide. So now we're talking about the skeletal muscle. Skeletal muscle, this is what we also call the voluntary muscle. In the vertebrates, it's most common of the three types of muscle. So the skeletal muscles are attached to the bones by tendons, and they produce the movement of the body part in relationship to each other. Next slide. Neuromuscular junction, this is like a chemical synapse that is formed by by the contact between like two motor neuron and a muscle fiber. It definitely helps with transmitting a signal to the muscle fiber, which causes the muscles to contract. Next slide. So the characteristics of the muscles, muscles are made out of bundles of muscle fibers to provide the force to the movement, to move the bone, and they assist in maintaining your posture, and of course assist with heat production. So it's important to be thinking about this, because someone who has less muscle mass, they're not going to be able to have maintain their body temperature as well as someone who does. Next slide. There are 4 steps of muscle contractions to excite, coupling, contraction, and relaxation. The process of contraction and relaxation requires energy, that's ATP. Contraction also requires calcium, right, which function as a catalyst. Acetylcholine released by the motor end of the motor neurons that initiate an action potential. Acetylcholine is then destroyed by the acetylcholine esterase, so an enzyme. Calcium is required to contract the muscle fiber and act as a catalyst for the enzyme needed for sliding together the action of the actin and myosin. All right, and then following that, following the contraction, the ATP transport the calcium out in order to allow actin and myosin to slide apart and then allow the muscles to react. So it's a constant process that takes place. Next slide. there's some body movement. It's important for you to understand the differences in each of these. All right, so the body movements. The first one on your list is flexion. Flexion movement in the sagittal plane, right? That decreases the angle of the joint and brings the two bones closer together. So flexion, bringing it closer to you. All right, and then extension, it is the opposite of flexion. So movement in the sagittal plane that increases the angle of the joint or distance between the two bones apart, right? And then you have hyperextension, which is extension that is greater than 180 degrees. And you have rotation, is the movement of the bone around its longitudinal axis, right? Rotation. And then abduction, not abduction, abduction, is moving a limb away in the frontal plane from the medial plane of the body. Spreading the fingers apart is an example. And then you have adduction, which is the opposite of abduction, which is movement of the limb towards the body midline. It's close to you, right? And then you have circumduction, which is a combination of all the movements commonly seen in a ball or a circuit joint, where the proximal end of the limb is stationary while the distant end of it moves in a circle, right? In a circle, right? And then dorsiflexion. Dorsiflexion is lifting the foot so that the superior surface approaches the shin, right? Standing on the heels, like you're standing on the heels, right? And this is a good technique to elicit someone who has deep vein thrombosis. And then you have plantar flexion. This is pointing the toes, right? Pointing the toes, plantar flexion, down, all right? Inversion is turning the sole of the foot medial-laterally, inversion, right? Eversion is turning the sole of the foot laterally. So one goes outward, the other goes inward, eversion. And you should pull up these different images online as well. Supination is forearm rotation laterally so that the palm is facing anteriorly and the radius and the ulnar are parallel, right? And then pronation, the forearm rotation laterally so that the palm faces posteriorly and the ulnar and radius are crossed, right? And then opposition, where it's touching the thumb to the other fingers, right? Next slide. There are some changes that you may see with aging. Okay, so some of the changes that would occur, definitely bone. There's loss of bone density, which accelerated especially after menopause, and then as a result, what you see is the bones are more fragile and then easy to break. So especially with age. So as people get older, the bones are more fragile, and so it's important to encourage them to continue to do weight-bearing exercises when they could and increase their calcium intake. And the joints are affected, and the joints, the ligaments and the cartilage are worn out between the joint, and which puts them at risk for degenerative joint diseases that you may see. The muscles get more atrophy, so maintaining heat loss, that is a significant issue as well with the elderly client. Next slide. All right, so now we're going to be talking about the nursing assessment of a client that comes in who has musculoskeletal issues. So it's important for us to do an interview. It's important to develop rapport by asking specific questions. You want to ask about their lifestyle, their activities of daily living, how, because musculoskeletal issues is going to affect them tremendously in that. You start off with a chief complaint, just doing a history of present illness of what brought them in terms of their complaint. So you want to find out about the complaint and the onset, how long it's been there, what are some aggravating factor, alleviating factor, if they've tried any treatment. Is this continuous, issues that they having, or is it intermittent? Is it sudden? Is it chronic? And how does it affect their current life? You want to find out about all the different medicine that they're taking, because there's certain drugs clearly that will put someone at risk for some of the musculoskeletal conditions that we have. You want to ask about their current medical condition, their past medical condition, their past surgeries, that they may have. Of course, assessing for pain. You start off with your subjective data, collect that, and then you do a physical assessment. You obtain a pain scale level, their vital signs, and the musculoskeletal, looking for alteration in sensation, and so forth. Next slide. All right, so physical assessment, you're going to look at their posture, that they have kyphosis, lordosis, look at the gait, are they upright, their bone integrity, is there any obvious signs of fracture or deformities, are they able, the joint, are they able to move the joints in the appropriate movement, their muscle strength, and skin, and size of their muscles, is the skin intact, any neurovascular status, such as is their pulses are palpable, is the area pale, is it warm, and is there paresthesia, paralysis, this kind of stuff for your physical assessment. Next slide. Risk factors for individuals with musculoskeletal includes autoimmune disorders, so it's important, like I said, to assess all that. Any calcium deficiency in their diet, to review their diet as well. Any degenerative conditions such as osteoarthritis, histories of falls, hyperuricemia, or any infection that they may have. Next slide. Additional risk factors are medicines such as the steroids that they may take, which would cause osteoporosis. Any metabolic disorders, thyroid conditions, any neoplastic conditions, cancer of the bone, obesity puts a lot of pressure. Postmenopausal woman, because of the estrogen protection that they've lost, can put them at risk for condition. Any trauma or injury. Next slide. All right, so there's many different diagnostic studies, evaluation of the client who has musculoskeletal condition. It starts with just a plain x-ray, which would be able to tell us, about any fracture. CT scan, MRI, arthrography, and bone density scan, other tests. Next slide. And then you have nuclear study, nuclear scans, endoscopies, and other studies such as arthrocentesis, electromyography, biopsy. Just to go a little bit detail on this is that with the x-ray, like I said, it's pretty simple. It's commonly used procedure to diagnose disorders of the musculoskeletal condition. And usually you just want to make sure that with an x-ray, it's to handle the injury area very carefully. Administer analgesics, prior to the procedure, because it could be painful. Remove any type of radio-opaque object that they may have, such as jewelry. And of course, the client, we're going to shield their reproductive areas, so their testes, ovaries, or pregnant abdomen. The client, they must lie still when we do the x-ray, and inform the client that exposure to radiation is minimal and it's not as dangerous, for cancers, because some people may be anxious about that. And also the healthcare provider who is going to do the x-ray, generally the radiation techs, they would need to wear a lead apron if they're going to stay in the room. And then you have other tests, like I said, the arthrosynthesis, and that involves, aspirating the synovial fluid, blood or pus, using a needle that is inserted in the cavity. Medication sometimes may be instilled into the joint if it's necessary to help with the inflammation. A consent is needed because it is an invasive procedure, and we need to apply compresses, after the procedure, and then trying to instruct the client to rest the joint for about 8 to 24 hours after the procedure. Also, we need to instruct the client to notify the physician if after the procedure there's fever or swelling in the joint. And then you have the anthrography or anthrogram of the knee. So this is pretty much a radiographic examination of the soft tissue of the joint structure that helps to diagnose trauma to the joint capsule or ligament. And generally there's a local anesthesia that is used, and a contrast media of sometimes air is injected in the joint cavity, and the joint is moved through a range of motion, as they're taking these different x-rays. And what you do is, for types of implementation, we want to make sure that, inform the patient of the fast, to fast from food up to 8 hours prior to the procedure, and assess for allergies to iodine or seafood prior to the procedure, and then obtain a consent form, and then inform the clients the need to remain as still as possible, except when they are asked to reposition. And we want to minimize the use of the joint for 12 hours following the procedure. And then usually, instruct the client that the joint may look a little bit edematous and tender for the first 1 to 2 days after the procedure, and they can use ice and analgesics as prescribed. Also informing the client that if edema in the tendonitis lasts longer than 2 days, then they need to follow up with their doctor. If the knee anthrography was performed, then we want to put an ACE bandage over the knee for like 3 to 4 days. But if just the air was injected, that they may feel something called crepitus, crepitus, in the joint for up to 2 days. Next slide. Next slide, we just talked about x-ray. Anthrocentesis, we just talked about that one. Anthrogram, we just talked about this. And anthroscopy is the next one. And so pretty much with anthroscopy, it is to provide an endoscopic examination of whatever joint that we're looking at. So the articular cartilage anomalies, we can assess that, and then if there's any loose bodies can be removed, and sometimes a biopsy may be performed during this procedure as well. So what we want to do is tell the client to to fast for 8 to 12 hours, obtain a consent form, and administer pain medication again, and elastic wrap. It's worn like 2 to 4 days post-op. And also instructing the client that walking without weight bearing is usually permitted after the sensation returns, but to limit the activity for about 1 to 4 days. Also instructing the client to elevate the extremities as often as possible for 2 days following the procedure, and to place ice on the site to minimize any type of swelling. We also want to reinforce with the patient the use of crutches, which may be used for 5 to 7 days post procedure when they walk. and then to advise the client to notify the physician if they have fever, increase in knee pain, or edema that is continuous for more than 3 days post-operative. Next slide. And the bone scan description, pretty much bone scan is where you use some radioisotope that is injected IV and collect in an area which indicate abnormal bone metabolism and some fracture if it exists. The isotope is excreted in the urine and feces within 48 hours, and it's usually not harmful. So this is why we encourage to hold fluid 4 hours prior to, but consent forms done, and removing any jewelry or metal object, and because it is the isotope is excreted in the urine, it's important for the client to drink at least 32 ounces of water if there's no contraindication, such as somebody who has heart failure, to promote that renal filtering of the excess isotope. From 1 to 3 hours after the injection, have the client void and then scan, and then the scanning procedure is performed, right? And we need to inform the client of the need to lie supine during the procedure, and then and that the procedure is usually not painful. No special precautions are required after the procedure because the minimal amount of radioactivity exists in the radioisotope. So we have to monitor the injection site for redness and swelling, and encourage oral fluid intake following the procedure. Next slide. So the bone or muscle biopsy, so it is pretty much done usually during surgery or through aspiration, or a puncture or needle biopsy. What we need is to obtain a consent form, and we want to monitor for bleeding, swelling, hematoma, and severe pain. We tell the client to elevate the site for 24 hours following the procedure to reduce any edema, and apply ice as prescribed to prevent any development of hematoma, and monitor for signs of infection. Also inform the client that mild to moderate discomfort is normal, usually following the procedure. Next slide. Electromyography, EMG. So this measures the electrical potential associated with skeletal muscle contraction, right? It's not EKG or ECG. This is EMG. That's looking at the electrical activity of the muscle. So what happens is the needles are inserted into the muscle, and recording of the muscular electrical activity are traced on recording paper through a scope. So what we do is make sure consent is signed. We are putting needles in someone's muscle. Instruct the client that the needle insertion is uncomfortable. Instruct the client not to take any stimulant or sedative 24 hours after, and inform the client that they may bruise, from the needle insertion. Next slide. Myelogram. Here what you see is that there's a dye that is injected into the subarachnoid space to detect any anomalies of the spinal cord and vertebrae. Preoperatively, again, a consent is needed, and we want to provide hydration for at least 12 hours before the test. Anytime you're given iodine, we have to assess for iodine allergies, asking about seafood and shellfish. Pre-medicate for sedation as prescribed, and remember, you must get consent before pre-medication is given. After the procedure, we are going to assess the vital signs and neurologic assessment frequently, and if it's a water-based dye that is used, then we want to elevate the head 15 to 30 for 8 hours. If it's oil-based, it's used and the client is laid flat as prescribed. There's usually headache that is associated with it too. If air is used, keep the head lower than the trunk, and then force fluid and monitor eyes and nose to make sure that the dye is excreted. Next slide. So now we're going to talk about the different types of musculoskeletal musculoskeletal injury. So yeah, the skeletal trauma and then injuries to the support structure. Next slide. So fracture is really described, generally according to the location and the type. So what is a fracture? It is a break in the continuity of a bone that's usually caused by some type of trauma or twisting as a result of muscle spasm or some indirect loss of leverage, or bone declassification and disease that result in osteopenia. So a fracture or break in the continuum of bone again occurs usually when the force that is applied exceeds the tensile or the compression strength of the bone, so more than what the bone can handle. The highest incidence that you usually would see with fractures are ages 15 to 24. It's usually young males, and then individuals greater than 65, and is often associated with osteoporosis. There are over 250,000 hip fractures annually in the United States. Next slide. So the types of fractures are complete or incomplete, open or closed. So open is formally referred to as compound, and closed is formally referred to as simple. So the complete fracture is the bone is completely separated, by a break into two parts, versus incomplete. So there is a partial break in the bone. You have open compound. Here the bone is exposed to the air through a break in the skin, right? And soft tissue injury and infections are common. Versus the closed or simple fracture, where you have the skin cover the fracture area, remains intact. Next slide. So complete fractures can be linear, oblique, transverse, or spiral, right? So again, complete fracture is a fracture where the bone completely separates by a break into two parts, right? A linear fracture is a fracture parallel to the long axis of the bone, versus oblique, where the fracture line at 45-degree angle to the long axis of the bone, right? So the break extends in an oblique direction. Versus transverse, so the fracture line at 90 degrees long axis of the bone straight across, right? Transverse, the bone is fractured straight across. Versus spiral, and usually what happens here is the break is partially encircles bone, so it's usually a spiral fractures like twisting, and it's usually seen in abuse when someone like with sudden pull and twist type of fracture. Next slide. Comminuted fractures, and these are bone is it's like pretty much crushed with three or more fragments. So the bone breaks into multiple fragments, right? Versus impacted, where the bone fragments are pushed into each other, right? You have pathological fractures. It's a fracture that is due to weakening of the bone structure by some type of pathological process, such as neoplasia, osteomalacia, osteoporosis, and usually you see like spontaneous fractures. And evolution, so here is when the fragment of the bone connected to a ligament breaks off from the main bone. And then you have depressed bone, where the bone fragments are driven inward. Next slide. So compression is a fractured bone compressed by other bone, right? So the fracture is wedged or squeezed into one on the other side of the bone. Versus the displaced bone, where you have the fracture with one, both, or all of the fragments are out of the normal alignments, displaced. And extra capsular. These are fragments that are outside the joint capsule, extra or intra, where the fragments are inside the joint capsule. Next slide. So you have incomplete fractures. Incomplete fractures are usually seen in younger individuals who do not have complete ossification of the bone. So a green stick fracture is one side of the bone is broken and the other side is bent, mostly common and seen in children, right? So with green sticks, you have the outer surface is disrupted, the inner surface is intact. Usually occurs with the proximal middle metaphysis or the radial, the ulnar, that kind of stuff. And then you have the torus, T-O-R-U-S. Here you have the bone cortex buckles, right? But does not break. It's common and seen with osteoporosis. Bone fracture, so it's bending of the bone, and then you have transcondylar fracture. Here, what you have is the separation of the cartilage surface from bone shaft. The stress factors are fractures that caused by abnormal stress or torque applied to a bone with normal ability to deform and recover. So joggers, dancers, military recruiters, those kind of individuals have stress fractures. Insufficient fractures that occurs in bone lacking normal ability to deform and recover. Next slide. So again, this slide is showing you the different types of fractures as we've just discussed. Evolution, again, is a fracture of the bone resulting from the strong pulling effect. Comminuted fracture, again, is a fracture with more than two fragments. Displaced and overriding fractures, again, involves a displaced fracture fragment that is overriding with the bone. And then you have the green stick fracture. Again, it's an incomplete fracture with one side splintered and the other side bent, seen in children. Next slide. Again, so just more of the same type. It's just showing you the spiral fracture, it's showing you stress fracture and transverse fracture and so forth. Next slide. Pathophysiology of fracture. So what happens with a fracture is that the peristernum and the blood vessels in the cortex, the marrow, and the surrounding tissue, with the fracture, those things get disrupted and bleeding will occur from the damaged end of the bone in the soft tissue. And then hematoma forms within the medullary canal between the fracture ends and beneath the peristernum. And then the bone tissue immediately adjacent to the fracture would die unless we intervene soon enough to heal the fracture. Next slide. So there is steps in how the fracture heals, right? So the inflammatory response is first vascular tissue, and then you see bone forming cells, callus formation, osteoblasts, and remodeling. So the intense inflammation response occurs with the hematoma formation. And usually within 48 hours, the vascular tissue invades the fracture area, and the blood flow to the entire bone is increased. The bone forming cells produce a procallus along the shaft and overbroken bones to bone, right? So the cells are formed. Osteoblast within the procallus, that's Procallus, synthesize collagen in the matrix, which kind of mineralize to form, a woven bone or callus, Callus. So the osteoclast continues with this callus replacement And then the remodeling occurs, in which the peristyle and the endostyle surface of the bone are remodeled to the size and shape of bone before the injury. All right. So to rephrase that, remodeling occurs in which the peristernum, that's PERIOSTEAL, and the endostyle surfaces of the bones are remodeled to the shape and size of the bone before the injury. Next slide. All right, so the speed of the healing depends on many factors. It depends on the severity of the bone disruption. It depends on the type and amount of the bone tissue that must be replaced. Is it spongy? The spongy ones heals a little faster. It depends on the blood supply and the oxygen to the site. It depends on the presence of growth and thyroid hormone, insulin, vitamins, and other nutrients. It depends on the presence of any other systematic diseases. It depends on the effect of aging, and of course the treatment that we have. And so what happens is usually the hematoma forms within hours, and then the procallus, that forms within days, and the callus formation that forms within weeks, and then replacement and remodeling can take up to 4 years. Next slide. So what are the clinical manifestations that someone has a fracture? Well, impaired function, unnatural alignment, swelling, spasm, tenderness, pain, impaired sensation, generally pain, right? They cannot move it, move it, and pain, swelling, spasm, and you can see the actual deformities. Next, and so pretty much you can, there's usually a pretty good indication if there's a fracture, making sure that the patient's going to have pain, and if they're not going to be able to move it. So can you move your arm? That's usually an indication that it may be fracture. But of course we have to be certain by doing some diagnostic tests that we talked about. Next slide. So we have to do an assessment. There's assessment and initial care of someone who comes in and was suspecting fracture. So assessment is going to assess for pain and tenderness over the area that is involved. We're going to assess for movements. Is there a loss of function? We're going to assess to see if there's any obvious deformities, like something bowing out or sticking out. Any crepitation, so that noise that is heard. Any edema, any erythema, ecchymosis, any spasm, or impaired sensation. Can they feel you or not? So initially what we want to do is to mobilize the affected area, and if it's a compound fracture, then we'll split the extremities and cover the wound with a sterile dressing. Next slide. So the intervention for fracture include reduction, fixation, traction, and cast. All right, next slide. So reduction. Reduction means that we are going to try to restore the bone to proper alignment, right? Close reduction is performed usually by manual manipulation, and it's usually done under local and general anesthesia. A cast may be applied following the reduction. Versus an open reduction, this involves a surgical intervention, right? May be treated with internal fixation devices, right? Like screws, plate, nails, wires. The client may be placed in a traction or cast following the procedure. All right, so next slide. So closed reduction, as shown in this picture, it is restoring the proper alignment, and it's usually done by manual manipulation. So clearly, you're going to manually manipulate someone's broken bone, and it's going to be painful. So that's why there's local and general anesthesia. Next slide. Internal fixation. It's a little different, right? So clearly you see the wires and screws, right? It involves a surgical intervention, right? And the client is placed on traction or cast, and you see the different wires and screws that are in there. So they have these devices inside. So it usually follows an open reduction, and like I said, involves the screws, plates, and nails to hold the fragment in alignment. It may involve the removal of a damaged bone or replacement with a prosthesis. We provide immediate bone strength. It will do that, but it also has a risk for infection because of the devices the things that are in it. So there's tension band wiring technique that can be used. There's compression plates to the lateral aspect of the femur. There's sliding hip screws. So that's why all these things put them at risk for infection. Next slide. This is a picture, an X-ray showing you internal fixation of the hip. Next slide. This is an external fixation. So internal is inside, external, the screws are visible to the outside. So really, really difficult and really put the patient at risk for infection, right? So with the external fixation, the external frame is utilized with multiple pins that is applied through the bone. It provides more freedom for movements than with traction. But clearly, you know, the patient is at risk for infection. Next slide. So types of fractures. Now we're talking about the extracapsular versus intra versus extracapsular fracture. All right. So talking about intracapsular and extracapsular hip fracture. The bone is broken inside the joint. That's what it means. So here, skeleton traction is usually applied preoperatively to immobilize and prevent pain. So the type of treatment that they would do for this type of fracture would be total hip replacement or internal fixation with the replacement of the femoral head with a prosthesis. So generally with the hip replacement, you want to tell the patient to avoid hip flexion to prevent dislocation or displacement, right? That was for intracapsular fracture. For extracapsular hip fracture, so here you have the fracture that occur at the greater trochanter, can be in the intratrochanter fracture, right? So usually the greater trochanter area. So the fracture is usually outside of the joint, and preoperatively what we want to do is treatment that includes, you know, balance suspension, and again to avoid the hip flexion to prevent dislocation or displacement. The surgical treatment usually include internal fixation with a plate, nail plate, screws, or wires. Next slide. This picture is showing you the hip replacement devices. Next slide. All right, so now total hip replacement, the post-operative, you know, pre-operative, just like your pre-operative chapter that we talked about, how you're going to collect some very important information to make sure that the client that is going into surgery is not going to get in trouble. So you ask about their current medical history, their past medical history, their current medicine that they're taking, any allergies that they have, especially allergies to anesthesia, and then of course do an assessment, and ensure pre-operative, intraoperative, so the nurse that's going to care for the client during surgery has to pay attention to monitor for complications, including placement complications, and then post-operatively to monitor the client to make sure that they are hemodynamically stable, and how to prevent other complications from occurring, or assessing for complications that the patient may have. Next slide. All right, so post-operative care that we are going to provide for client. One of the things that we want to teach them is to maintain the leg and hip in proper alignment when it comes to the hip replacement, to prevent flexion or external or internal rotation, to make sure that the client is turned from back to the unaffected side. Do not position to the affected side unless the physician has prescribed something. Maintaining the leg abduction to prevent any internal or external rotation. To use a trochanter pillow or roll to prevent external rotation. To ensure that the hip flexion angle does not exceed 60 to 80 degrees. So to elevate the head of the bed 30 to 45 degrees for males only, because you don't want it to be dislodged. Ambulate as prescribed generally, and avoid any weight bearing on the affected leg as prescribed, and instruct the client to use a walker to avoid weight bearing on that affected hip. Keep the operative leg extended, and support and elevate when getting out of bed. Avoid the hip flexion greater than 90 degrees, and avoid low chairs when out of bed, so including the toilet should be raised. Monitor for wound, for infection or hemorrhage. Monitor for circulation and sensation, so temperature, color, and movement, paresthesia. Maintain a hemovac or JP drainage in place, and maintain the compression to facilitate the drainage, and monitor for any monitor for the output from the drainage. And maintain the use of anti-embolism stockings, and encourage the client to flex and extend their feet and their ankles. Instruct the client to avoid crossing the legs and bending over, and of course physical therapy usually begins the post-operative exercises as prescribed. Next slide. So total knee replacement is an implantation of a device to substitute for the femoral, for the joint of the knee. And post-operatively, what you want to do is to monitor the incision site for drainage and infection. We're going to maintain the hemovac or JP drainage if it is placed. We also want to begin continuous passive motion exercises, the CPM, 24 to 48 hours as prescribed, to exercise the knee and provide moderate flexion and extension. We're also going to administer analgesics before the CPM is used to decrease the pain level, and the leg should not be dangled to prevent dislocation. Also prepare the client for out-of-bed activities as prescribed by the surgeon, and avoid weight bearing, and instruct the client in crutch walking. Next slide. So this slide is showing you a knee prosthesis that is implanted. Next slide. And this is the continuous passive motion that is on the client's knee, and it just increases the extension by increments, and usually this is ordered by the physician how high we should increase the level. Next slide. Cast is our next discussion. Okay. So cast is made of plaster or fiberglass. It's usually used to provide immobilization of bone and joint after a fracture or injury, right? So in terms of implementation, what we want to do is keep the cast and the extremity elevated. Usually we wanted to allow it to a wet cast to 24 to 48 hours to dry. The synthetic cast can dry in 20 minutes. 20 minutes. Handle a wet cast with the palms of the hand until it's dry. Turn the extremity unless it's contraindicated usually, so that all sides of the wet cast will dry. And then heat can be used to dry the cast, so the cast will change from dull to like shiny substance when it's dry. Examine the skin and cast for pressure areas. We're going to monitor the extremity for circulation impairments, and that includes pain, swelling, discoloration, tingling, numbness, coolness, or diminished pulse. They call it the P's that you're assessing for. And usually, if there's pain, swelling, all those things I just described, then it's maybe something referred to as compartment syndrome. Notifying the physician immediately, because that tells you the circulation is compromised. Prepare for cutting the cast if the circulation impairment occurs, and pedal the cast or maintain maintain the smooth area edges around the cast to prevent crumbling of the cast material. Monitor the client's temperature. Monitor for presence of foul odor. So that may indicate infection. Monitor the drainage and the circle area of drainage on the cast to show an increase. Monitor for the warmth of the cast, and monitor for wet spot, which may indicate a need for drying or the presence of drainage under the cast. If an open drainage area exists on the affected extremity, a cutout portion of the cast or window will be made by the physician. Allow the client not to stick object inside of the cast so nothing goes in, and then teach the client to keep the cast clean and dry, and of course instruct the client on isometric exercises to prevent muscle atrophy. So cast can be in different body parts as shown in this slide that we're looking at. So short arm, long arm cast, long leg cast, short leg cast, and double hip spica cast, single hip, and body jacket cast. All right, next slide. So it's important when someone has a cast to educate, because you educate them why it's necessary, how the plaster may feel, the extent of immobility. Apply ice directly over fracture for 24 hours at interval, on and off, and then instruct on sharp object into the cast that they cannot, exposing the cast to air as soon as possible, as much as possible, and prevent any skin irritation. Clean the area with a warm washcloth and attend to complain of pain. Neuro checks are a must. So teaching like the young kids how to move, like part of the game that they can play is like sure that I can move my fingers. Movements means that it's not paralyzed, right? So you can move it. Next slide. So traction is our next discussion. So traction is the exertion of a pulling force that is applied in two directions to reduce and immobilize a fracture. It provides proper body alignment and reduce muscle spasm. So tractions are good. So for implementation, what you need to do is to maintain proper body alignment, ensure that the weights are hanging freely and do not touch the floor, because there's different types of traction. There's skin traction and there is skeleton traction. All right, so this is the general expectation for a traction. So do not remove or lift the weights without a doctor's order. Ensure that the pulleys are not obstructed and the ropes are in the pulley and they move freely. Place the knots in the rope to prevent slipping, and check the ropes for fraying. Some of the nursing responsibility is for us to prevent complications, manage pain, maintain alignment, checking the equipment, assessing for complication of other organs, prevent external rotation of the hip, prevent foot drop, educate and encourage mobility, explain the amount of movement allowed, use of trapeze, check traction, avoid adding weight, check the ropes and pulley, and avoid manipulation of the pins, maintaining counter traction, skin, and toileting. So those are the nursing responsibilities. Next slide. So skin traction is the mechanically applied to the bone using skeleton traction using pins, wires, and tugs. And usually when skeleton traction is used, so we want to, because of the things that are used, the pins and wires and so forth, so we have to monitor for color, motion, and sensation. Want to make sure there's adequate perfusion to the area. Monitor the insertion site for redness, swelling, or drainage, because they are at risk for infection. Provide insertion site care as prescribed to prevent the infection. Next slide. Skin traction. Skin traction is applied by the use of elastic bandage or adhesives. It's less weight. Skeleton traction, more weight is applied. Skin traction, fewer weights are applied. So the different types of skin traction that we may use are cervical, bucks, Bryant's, pelvic, and Russell's traction. Next slide. So cervical traction, that's what you see in the picture here. It relieves the muscle spasm and compression in the upper extremities and neck. So uses a head halter and a chin pad to attach the traction as seen over in your picture. It uses powder to protect the ears from friction rub. They are at risk for impaired skin integrity. Position the client with the head of the bed elevated 30 to 40 degrees and attach the weight to the pulley system over the head of the bed, so the weight is hanging down. It's used to alleviate the muscle spasm, so it immobilizes a lower limb by maintaining a straight pull on the limb with the use of weight. Next slide. So the head halter traction is a type of skin traction also. It kind of equivalent to spinal traction, but the head halter traction is used in cervical alignment and injuries. It is usually used for shorter period to reduce discomfort. There's two types that they generally use, but the areas of concerns are the complications that have to do with this. There's pressure on the chin area, so we need to assess for pain and skin impairment on the chin that is usually caused by excessive weight of the traction. Inadequate pattern of the chin strap or traction pull that is not evenly distributed between the chin strap and occipital strap. Excessive pull on the chin can be relieved by changing the direction of the traction rope and the apparatus, so that the more pull is placed on the occipital strap. So you can also have pressure on the occiput, which can cause skin trauma, headaches, or occipital neuritis. Again, adequate padding can prevent most of the skin trauma. The occipital headaches are relieved with pressure on the occiput, and it's decreased, or the line of pull must be lowered to place more pull on the chin. So what they see is like a constant dull pain in the occipital area, which may suggest neuritis. Another issue that they may have is pressure on the temporomandibular joint, so the TMJ joint. So, and you would, a patient would develop pain with a large amount of weight is used over a long period. The most predominant symptom is pain in the angle of the jaw, often radiating into the ear. The use of a bite block, right, usually relieves this TMB pain. Other problems that they may have is mechanical problems, which involves the weight resting on the floor, breaking the rope, and tangling the rope in the pulley. All right, next slide. So with the buckskin traction, here what you have is a boot appliance is applied to the attach to the traction, and the weight is attached to the pulley, like you see there, which allowed the weight to hang freely over the edge of the bed. The weight, because it's a skin traction, the weight should not be more than 5 pounds, and elevate the foot of the bed to prevent, to provide the traction. Next slide. Now we're talking about the pelvic skin traction. Again, this is a skin traction, not skeleton traction. So pelvic skin traction is used to relieve the low back pain, hip or leg pain, and to reduce any muscle spasm. And here what we do is we're applying the traction snugly over the pelvic and iliac crest and attach to the weights. We use measures as prescribed to prevent the client from slipping down in the bed. And generally, if you walk into the patient's bed and you see, the weights on the floor, the first thing you want to do is, look at your position of the patient and pull the patient up in the bed. And if that happens, then that should take the weights off the bed, off the floor. Next slide. So this is a balanced suspension. That's what you're looking at here. With the balanced suspension, it's used with skin or skeleton traction. So usually used to approximate the fracture of the femur, tibia, or fibula. It's produced by a counter force other than the client, right? See, there's other forces other than the client. So here, so the patient here should be on positioning the client in the low fowlers, either on the side or back. Maintain a 20-degree angle from the thigh to the bed. Excuse me. We have to protect the skin from breakdown, and you can see that. Provide pin care if the pins are used with skeleton traction. Clean the pin site with sterile normal saline and hydrogen peroxide or betadine as prescribed per the agency procedure. Next slide. So the down loop skin traction is another form of traction that is used. This has it's a horizontal traction to align the fractures of the humerus. The vertical traction maintains the forearm in proper alignment. You see that? Here, what the nurse needs to do is the care is similar to bucks traction. There are some complications that you should be mindful of: skin breakdown, pain, paresthesia, foot drop, nerve pressure, diminished pulses, pressure ulcer, infection, swelling, drainage, foul odor, fever, pain, and nerve dysfunction, right? Do you see how the arm is, positioned this way? Next slide. So there are some complications of fracture. There's fat embolism, compartment syndrome, infection and osteomyelitis, avascular necrosis, pulmonary embolism, venous thrombosis, and delayed union and Inani union. And we're going to talk about each one of this. Next slide. So fat embolism. Fat embolism is when you have an embolism originating in the bone marrow that occurs after a fracture. So clients with long bone fractures are the ones that are at greater risk for developing a fat embolism. Usually occurs within 48 hours following the injury. What you see is restlessness, mental status changes, tachycardia, tachypnea, hypotension, dyspnea, and you see petechial rash over the upper chest and neck. In terms of implementation, once you suspect this, you want to notify the physician immediately and treat the symptoms as prescribed to prevent further respiratory failure and death. Next slide. Compartment syndrome is the next complication that we should be mindful of. With compartment syndrome, there's increased pressure within one or more of the compartment, which is causing massive compromise of circulation to the area that was affected. So by impairing circulation, it leads to decreased perfusion and then, of course, tissue anoxia. So within 4 to 6 hours after the onset of a compartment syndrome, the damage, the neuromuscular damage, is irreversible. So it's important for us to assess soon and take care of the problem sooner. So what are some of the findings that you will see, the assessment findings? There's increased pain. So one of the first P, pain. There is paresthesia, right? So loss of sensation. There's paralysis. There is pulselessness, because you're supposed to have pulse. Pulse tells you circulation is good. You know, there's pallor. It's pale, right? And again, this needs to be addressed immediately, so you must notify the physician immediately. Next slide. The next complication is infection and osteomyelitis. Okay, so pretty much this can occur. Infection occurs because there's some type of disruption of the skin, the largest organ, right? So once it's open, the infection can invade the bone tissue. So some of the assessment findings of someone who has osteomyelitis is fever, pain, erythema in the area, of course, surrounding the fracture, tachycardia, and if you do the WBC, they will be elevated. So what we want to do, again, is also notify the physician immediately, because we need to initiate aggressive IV antibiotic therapy. Next slide. Next complications is avascular necrosis. It's pretty much tells you exactly what that is, but it is an interruption in the blood supply to the bone tissue. Everything needs supply of blood. If it doesn't happen, it dies. So in this case, it results in the death of the bone. So what are some of the findings, assessment findings? There's pain, and then there's decreased sensation. Again, notify the physician if the pain or if there's pain or there's decreasing sensation, and prepare the client to remove the necrotic tissue, because it serves as a focus of infection. So we have to remove the dead cells or the dead bone. Next slide. So pulmonary embolism, that is caused by immobility. That's usually precipitated by the fracture that they have, right? So you're not getting up, you're not active, then blood clot forms. So what are some of the assessment findings that suspect this? So there's restlessness, there's apprehension, dyspnea, diaphoresis, and arterial blood gas changes. So again, notifying the physician immediately and prepare to administer anticoagulant therapy. So to prevent existing clots, to prevent blood clot is heparin, coumadin. To dissolve existing ones, you do the thrombolytics, right? The clot busters. Next slide. So venous thrombosis, which can lead to pulmonary embolism, is a complication of it. So because of immobility, there is formation of blood clot. We want to make sure that while the patient is in bed, to be moving their extremities, but also to assess for signs of DVT. dorsiflexion, and if it's positive pain on the back of the calf and increase in warmth, then we want to suspect and probably immobilize the patient and get a Doppler to confirm if there's blood clot. If there is, then we want to make sure it's a dissolve. Otherwise, it could be dislodged, so we want to put the patient on bed rest. Once we know that they have a DVT, they're going to be taking Coumadin to, anticoagulant to dissolve it. So as a nurse, you should know the antidote for these drugs. Next slide. Okay, so for here, broken bones, do not heal even when they've gotten the best surgical or non-surgical treatment. And sometimes there are risk factors that put this patient at risk for failure to heal. And when a bone fails to heal, we call that non-union, right? And a delayed union is when the fracture takes longer than usual to heal. And so pretty much your assessment findings, you see similar signs and symptoms of, the fracture that is not healed is taking longer and it's healing, but it's not. And so it's important for the nurse to recognize that and identify whatever factors that may contribute to failure to heal, such as the nutritional status, are they diabetic? Because the diabetics will take longer to heal and so forth. Are they resting? Are they following the instructions that they've been given? Next slide. So other skeleton traction that we want to pay attention to are listed in the slides: dislocation, subluxation, and injuries to support structure, such as tendon tear, ligament strain, sprain, tendonitis, and bursitis. But I want to talk about, two of the most common ones that you may see are the strains and sprains. So a strain is an excess stretching of the muscle or tendon. Usually, involve, management involves cold and heat application, exercise with activity limitation, and taking some anti-inflammatory drugs, and muscle relaxing, so NSAIDs. Surgical repair, may be required for a very severe strain. Usually there's a rupture of the muscle or the tendon. And then sprain is an excess stretching of a ligament, right? Usually caused by twist and motion. So whereas strain is stretching of the muscle, this is sprain is the excess stretching of the ligament. So that's characterized by pain and swelling, and management involves rest, ice, and compression bandage to reduce the swelling and provide joint support. Casting may be required for moderate sprains to allow tear or heel to heal. All right, so the surgery may be necessary for severe ligament damage. The management of contusion, sprain, and strain. And so there is a mnemonic or acronym that you should be familiar with, and that is RICE, R-I-C-E. So R is rest in, ice is apply ice, C is a compress, and E, elevate the extremity. Next slide. Other soft tissue injuries are, dislocation, subluxation. So pretty much with this dislocation, you have severe injury of the ligament structure that surround a joint. It results in the complete displacement or separation of the articular surface of the joint, versus subluxation, which is partial or incomplete dislocation of the joint surface. And generally what you see is the manifestations are similar to dislocation but less severe. Treatment to dislocation, it's very similar as well. So and usually dislocation is resulting from overwhelming force transmitted to the joint that causes disruption of soft tissue surrounding the joint. The joint most frequently involved are the thumb, the elbow, the hip, and the patella. The most obvious clinical manifestation is usually asymmetry of the musculoskeletal contour. So they look shorter on the affected side. Also pain, tenderness, loss of function, swelling of the soft tissue. Complications include open joint injuries, avascular necrosis, and damage to the adjacent neurovascular tissue. Neuromuscular assessment is critical, and X-ray can help identify stuff. We can aspirate the joint to determine the presence of blood or fat cells. Fat cells indicate probable intra-articular fracture. So nursing management include directed towards pain relief and support and protect the injured joint. Carefully, regular rehab program is definitely important for these guys. Next slide. Carpal tunnel syndrome is associated with occupations that require continuous wrist movement. So secretaries, people that sit in front of the computer all day long, and usually there's pain that they complain about. So some of the pain that the symptoms that they may complain about are burning sensation, tingling and itching, numbness in the palm of the hand and thumb or index and middle fingers. There are some, so in terms of assessment, you're going to assess the median nerve, which begins to lose function because of the irritation pressure around it. And so, it could be debilitating, especially if this is something that someone used to work, and there are ways to use some treatment. It's pretty much lifestyle modification to avoid. So for those who are in front of a computer, they can use ergonomic pads to make sure that the flexion is not as severe. Certain stretching and strengthening exercise that can also help. And immobilization, usually they can splint it, and medications that can be given to help with the inflammation, so your NSAIDs and so forth. Things get worse, then of course surgery can be discussed as well. Next slide. All right, so these are sport-related injuries, that rotator cuff, the tennis elbows, that kind of stuff. So pretty much rotator cuff is the shoulders or sustain a tear usually as a result of trauma, and it's usually characterized by the shoulder pain and the inability to maintain abduction, not adduction, ABD, of the arm at the shoulder. So they do the drop arm test. Management for this includes NSAIDs, physical therapy, sling support, and ice and heat application. Surgery may be required if the medication is unsuccessful for those who have a complete tear. Next slide. So crutch walking is really important for clients who have injuries affecting their legs. So it's important for us to have an accurate measurement of the client. For the crutch is important because of incorrect measurement could damage the brachial plexus. So the distance between the axilla and the arm piece of the crutch should be 2 finger breadths in the axillary space. The elbow should be slightly flexed 20 to 30 degrees when walking. When ambulating with the client, we want to stand on the affected side and instruct the client never to rest the axilla on the axillary bars. Instruct the client to look up and forward when they're ambulating because they can fall, and instruct the client to stop ambulation if numbness or tinglings in the arms or hands occur. Next slide. These are the different types of gait walk. Okay, so it's a different type. Normal gait is, it's the method of walking, right? So we try to resemble the best gait for the patient is determined based on the injury, right? When it comes to the different types of the gait that we want to maintain. They are 4-point gait. You see that on the bottom of the slide that I'm looking to. And it's usually used for clients who can bear weight on both legs, right? But not too much, but they can bear weight on both legs, right? 4-point gait. And the 4 points are, you're using 4 points, the patient's 2 foot plus the point, the gait, the crutch, the gait itself. All right, and then you have the 3-point gait. It is used for patients who can bear weight on only one leg, right? And then you have the 2-point gait, and that is used for patients who can bear weight on both legs and have mastered the 4-point gait, right? And then you have swing to gait, swing to the gait, right? So here, what is happening is, it's used for the patient who can bear weight on one or both legs, has good shoulders and arm strength, and a good sense of balance and coordination. All right, and then swing through the gait. It is used for a patient who can bear weight on one or both legs, has great shoulder and arm strength, and an excellent sense of balance and coordination. So swing to the gait, right? So if you're paralyzed, you can swing through the gait, right? Again, the crutches are supports that helps the patient to ambulate and walk, right? So ambulate means walk, right? Ambulation means walk. Next slide. You have the single and quad foot canes. Pretty much they are made out of lightweight materials with a rubber tip at the bottom. You can see that. They stand at the affected side of the client when ambulating. The handle should be at the level of the client's greater trochanter. The client's elbow should be flexed at a 20 to 25 to 30 degree angle. What we want to teach the client who uses a cane is to hold the cane close to the body and hold the cane in the arm on the unaffected side, so that the cane and the weaker leg can walk together with each step. Move the cane at the same time as the affected leg, right? And inspect the rubber tip regularly to see if it's worn out. For the hemi cane or quad foot canes, what we need to do here is to use, it's used for clients who have to use only one upper extremity. The hemi canes provide more security, right, than a quad 4 cane. However, both types provide more security than a single tip. It makes sense, right? Position the cane at the client's unaffected sides, always on the unaffected side. That's what needs support, with a straight, non-angular side adjacent to the body. And then position the cane 6 inches from the client's side with the arm grip level at the greater trochanter. That's trochanter. Next slide. So these are walkers, right? So you stand adjacent to the client on the affected side, like you see there, right? And instruct the client to put all 4 points of the walker flat on the floor before putting weight on the piece. And instruct the client to move the walker forward and to walk into it. We always want to support the weaker side. Next slide. Herniated disc. So here what you have is the nucleus of the disc protrudes into the annulus, annulus, causing a nerve compression. And it's different types of this herniated disc is cervical or lumbar, right? Cervical or lumbar. Next slide. This is a cervical disc, or cervical colors used for the cervical herniation. All right, so it holds the head in a neutral or slightly flexed position. See the cervical collar? So it holds in neutral. The client may have to wear a cervical collar 24 hours a day. And so we need to inspect the skin under the collar for irritation. When the pain subsides, the client is taught cervical isometric exercises to help strengthen the muscle. So usually this herniation would occur at C5 to C6 and C6 to C7 interspace. What happens is it causes pain and stiffness in the neck, the top of the shoulders, scapular, upper extremities, and the head. And because of that, there's going to be paresthesia and numbness to the upper extremities. So what do we do? What are some of the nursing implementation? So we're going to provide bed rest to relieve pressure and reduce the inflammation and edema. We're going to provide immobilization, using cervical collar, traction, or brace. We're going to apply heat, moist compresses to increase the blood flow and relax the spasm. We're going to instruct the client to avoid flexing, extending, or rotating the neck. We're going to instruct the client to avoid long periods of standing. This is all making sense. We're going to instruct the client that while they're sleeping, to avoid the prone position and keep the head, spine, and hip in alignment. To instruct the client in the use of anesthesia, analgesics, sedatives, anti-inflammatory agents, and steroids as prescribed. Prepare the client for corticosteroid injection into the epidural space, right? So that may need to be happen. And assist the client with the application of cervical collar or cervical traction. Next slide. Lumbar herniation, right? So pretty much what you see here is L4 to L5 and L5 to S1 are the most often occurs with this herniation. And sometimes postural deformities occur and produce muscle spasm, weakness, sensation, and alteration in deep tendon and the tendon reflexes. The client usually experiences low back pain and muscle spasm with radiation of the pain into one hip and down the leg, sciatica. That's what it's called, sciatica. Pain is aggravated by bending, lifting, straining, sneezing, coughing, and is usually relieved by rest. So your nursing implementation for these guys that have herniated disc to the lumbar section will be to provide bed rest, apply moist heat and massage as prescribed, instruct the client to sleep on the side with the knees and hips in position of flexion and with pillow between the legs. Apply the pelvic traction as prescribed to relieve the muscle spasm. Begin ambulating gradually as the inflammation and edema will subside, and instruct the client to use muscle relaxant, anti-inflammatory medications, and steroids as prescribed. And instruct the client to use the corset or brace as prescribed. And instruct the client regarding correct posture when they are lifting, sitting, and walking. And instruct the client to lift objects by bending the knees and keeping the back straight, avoiding lifting anything above the elbows. And instruct the client regarding weight control program as prescribed. And instruct the client in an exercise program as prescribed to strengthen the abdominal and back muscle. Next slide. This is showing you pictures of how to care for the back. Next slide. All right, so this is the disc surgery that could be done. Chemolysis. Here we injection to dissolve the affected disc. Dissectomy, the removal of the herniated disc, tissue, and related matter. Discectomy with infusion, fusion of the vertebrae with the bone graft. Laminectomy is the division of the lamina of the vertebrae, or laminectomy, which is the removal of the lamina. Next slide. So a disc surgery, there are, according with all surgery, you have preoperative, intraoperative, and postoperative. Your preoperative duties include reassure the client that the surgery will not weaken the back, and instructing the client regarding coughing and deep breathing exercises prior, making sure that we have a complete history of patients' current medical issues, medication, lifestyle, and instruct the client about log rolling and range of motion exercises. So prior to the surgery, you teach them how to avoid some of the complications that can occur after surgery. Post-operatively, for the cervical disc, so monitor for respiratory difficulty, it makes sense. Encourage coughing and deep breathing exercises. Monitor for hoarseness and an inability to cough effectively, because this may indicate laryngeal nerve damage. Use throat spray, for sore throat, and do not use those that numb the throat to avoid choking. Monitor the wound for drainage and provide a soft diet if the client complains of dysphagia. Monitor for sudden return of radicular pain, which may indicate the cervical spine has become unstable. Post-operatively, for the lumbar disc, we want to monitor for hemorrhage. We want to monitor the sensation and motor ability of the lower extremities, as well as the color, temperature, and sensation of toes. We want to monitor for urinary tension, paralytic ileus, and constipation. We want to initiate measures to prevent constipation, such as high fiber diet, increased fluid, and stool softener as prescribed. When turning and repositioning the client, we place the bed in the flat position and the pillows between the legs. So we're going to log roll this client without twisting the client's back. When positioning the client, the pillow is placed under the head with the knees slightly flexed. We want to avoid extreme knee flexion when the client is lying on the side. So to do so, we're going to assist the client out of bed. We're going to raise the head of the bed while the client lies on the side. The client's head and shoulders are supported by the first nurse, and then the nurse pushes herself to a sitting position. The client pushes themselves to a sitting position, and the second nurse aces the leg over to the side. All right, so we're going to instruct the client to avoid sitting because it places a strain on the surgical site. And administer narcotics and sedatives as prescribed for the pain and anxiety that the patient may experience. Encourage early ambulation to avoid some of the complications that goes with immobility, and assist the client with the use of back brace or corset if it's prescribed. Next slide. So amputation of a lower extremity, it's pretty much the removal of a lower limb or part of the limb. Next slide. So this picture shows you how it's done. So the amputation, the flap amputation, and then a secured flap. Next slide. So post-operatively, what we want to do for clients who've had an amputation of the lower extremity is to observe for signs, observe for and prevent contractures, right? We're going to monitor, of course, the vital signs. Okay, we're going to monitor for signs of necrosis and neuroma. We're going to evaluate phantom limb, that's PHANTOM, limb, LIMB, sensation and pain. Explain sensation and the pain to the client and medicate the client as prescribed. Check the physician's order regarding positioning. Generally, if prescribed during the first 24 hours, We want to elevate the foot of the bed to reduce edema. Then keep the bed flat to prevent hip flexion contracture. Do not elevate the stump itself because elevation can cause flexion contracture of the hip joint. After 24 to 48 hours post-operatively, so position the client prone, if prescribed, to stretch the muscle and prevent flexion contraction of the hip. So this is a problem, right? In the prone position, place a pillow under the abdomen and stump and keep the legs close together to prevent abduction, not abduction. Maintain application of ACE bandage or elastic stump shrinker as prescribed to provide stump shrinkage. Remove and rewrap the ACE bandage or elastic stump 3 to 4 times daily as prescribed. Wash the stump with mild soap or water and apply and pat the skin dry if prescribed. Massage the skin towards the suture line to increase the circulation. Prepare for cast application if prescribed to prepare the stump for prosthesis. Encourage the client to look at the stump, body image disturbance. Encourage verbalization regarding loss of body parts and assisting the client to identify coping mechanism to deal with the body loss. Mark any bleeding and drainage of the dressing if it occurs, and keep a tourniquet at the bedside to help with bleeding, and monitor for thromboembolism. Next slide. So this picture is showing you how the stump is wrapped. Okay, next slide. So now we're talking about below the knee amputation. So pretty much it's below the knee, so the surgery is below the knee. And we want to prevent edema, and we do not allow the stump to hang over the edge of the bed, and we do not allow the client to sit for long periods to prevent contractures. Next slide. So what we want to do is to prevent, it's rehabilitation pretty much. Rehabilitation is really important after the surgery. So we're going to instruct the client in crutch walking, prepare the stump for prostheses, prepare the client for fitting of the stump, and instruct the client in exercises to maintain the range of motion and provide psychosocial support to the client. And place a sandbag or rolled towel along the outside to prevent the hip, the thigh to rotate. Next slide. So now we're going to talk about disorders of the bone, and we're talking about the metabolic bone diseases, infectious bone diseases, and bone tumor. Next slide. Infectious bone disease, osteomyelitis, is difficult to treat, and it could cause, it's extensive. It can cause extensive physical disability. And here what happens is the bacteria invade the microscopic channels in the bone, which makes it difficult for the cells and biochemicals to reach. The bone cells have little capacity to replace the bone, so that the bone is going to be destroyed by infection. So you have infections that are entering from the outside of the body versus endogenous pathogen. All right, so you have those that are on the outside versus the ones that are inside from hematology. Next slide. So pretty much osteomyelitis can be caused by the interruption of the integrity of the skin. The infection invades the bone tissue And what you see is that there's pain, fever, erythema in the area that surrounds the fracture. There is tachycardia, elevated WBCs, and some of the nursing implementation is notifying the physician and prepared to initiate an aggressive IV therapy. Next slide. Bone tumor. The highest incidence is in adolescents and adults greater than 60 years old. The signs and symptoms are usually vague, usually attributed to minor trauma, degenerative changes, and inflammatory conditions. Diagnosis, we can use x-ray, CT scans, and MRI, so make sure that you're familiar with these different diagnostic tests and your nursing consideration. Early diagnosis is important to allow survival rate and preservation of the affected limb. Next slide. Disorders of the joint. That's what we're talking about now. You can have non-inflamed joint disease and inflamed joint disease. Next slide. The inflammatory joint disease are rheumatoid, ankylosis, and gout arthritis. Next slide. Let's talk about each one of them. So rheumatoid arthritis, what happens here is a chronic systemic inflammation disease. The etiology may be related to a combination of factors, environment, and genetic. It leads to the destruction of the connective tissue and synovial membranes within the joint. Weakness, and leads to the dislocation of the joint and permanent disability, as you see on the slide. So exacerbation are increased by physical and emotional stress. Risk factors include exposure to infectious agents, fatigue, and stress. Vasculitis can cause the malfunction and eventually failure of an organ or system. Your assessment findings are inflammation, tenderness, stiffness of the joint, moderate to severe pain, and morning stiffness that's usually longer than 30 minutes. It's one of the differentiating factors with rheumatoid arthritis. Joint deformities, muscle atrophy, and decrease in the range of motion. Spongy, soft feeling in the joint, low-grade temperature, fatigue and weakness, anorexia, weight loss, and anemia. It's elevated sedimentation rate and positive rheumatoid factor. Those are the tests that are done. X-ray will show some joint deformity, and the synovial tissue biopsy will present with inflammation. Next slide. So it's showing you the deformities and the atrophy, Boutonniere's deformities, swan neck deformities. It makes it hard for body image, for nursing care, for ADLs, and so forth. So rheumatoid factor will be a test. It's usually helps us diagnose rheumatoid arthritis. And usually the values are non-reactive if it's 0 to 39. Weakly reactive is 40 to 79, and reactive if the result is greater than 80. Next slide. So the nodules are, there's pain and there's salicylate that can be used for that, aspirin. When you give the anti-inflammatory drugs, you can give aspirin, you can give NSAIDs. We have to monitor for the effects such as tinnitus, gastrointestinal upset or prolonged bleeding time, and administer with meals or snack for gastric irritation, and of course for abnormal bleeding and bruising. Next slide. So we can also use NSAIDs steroids, anti-neoplastic drugs, and gold salts. There's all the different types. So NSAIDs may be prescribed in combination to the aspirin. Monitor for side effects, again, GI, central nervous system manifestations, skin rash, hypertension, fluid retention, and changes in renal function. The steroids, again, administered during periods of exacerbation, and commonly used agents are ineffective. So here we got to make sure that when you give your steroids, worry about the complication that goes with it, hyperglycemia, the immunosuppression, and so forth. The anti-neoplastic medications, it's usually prescribed in clients with life-threatening rheumatoid arthritis. The gold salts administered in combination with the salicylate and NSAIDs to increase the remission and decrease the pain and inflammation. Next slide. So physical mobility and self-care is very important. So we want to encourage activity and promote independence as much as possible. Next slide. Some of the nursing diagnoses that are relevant here for these guys are fatigue and body image disturbance. Fatigue, what we want to make sure is we find out the factors that may contribute to the fatigue. As a nurse, monitor for signs of anemia, administer iron, folic acid, and vitamin supplements, monitor for drug-related blood loss by testing for occult blood, instruct the client in measures to conserve their energy, such as pacing the activity, resting, delegating some tasks. For the other nursing diagnosis, body image disturbance, so you've got to assess the client's reaction to the changes that is happening, encourage the client to verbalize their feelings, assist the client with self-care activities and grooming, and encourage the client to wear street clothing. All right, next slide. So sometimes there's surgical intervention for rheumatoid arthritis, synovial-vectomy, so removal of the synovia to help maintain joint function. They could do bone fusion of the joint to regain some mobility, arthrodesis, or joint replacement, arthroplasty. So replacement of the diseased joint with artificial joint. We generally do this to try to restore the motion to the joint and function to the muscles, ligaments, and other soft tissues. Next slide. Ankylosing spondylitis. This is a chronic inflammatory disease characterized by a stiffening and fusion, which is the ankylosis part of the spine. It is systemic. You see, it's autoimmune disease. It differs from rheumatoid arthritis in that the primary sites of inflammation in the rheumatoid arthritis is the synovial membrane. In this situation, the primary site is the point at which the ligaments, tendons, and joint capsule insert into the bone. Enthesis, that's E-N-T-H-E-S-I-S. Primary is usually developed in the late adolescent or young adult. And you can have secondary type, which is usually seen in the older group. Signs and symptoms that they will present with is low back pain and stiffness, persistent progressive pain, usually worse after a prolonged rest, and it's alleviated by activity. And treatment is anti-inflammatory and analgesics and exercise. Next slide. Gout. Gouty joint. Gout is a systemic disease in which the uric crystals deposit in the joint and other body tissue. This will lead to abnormal amounts of uric acid in the body. Primary gout results from a disorder of purine metabolism. Purine metabolism, that's P-U-R-I-N-E metabolism. Secondary gout that occurs or involves excessive uric acid in the blood that is caused by another disease. There are phases of gout. The first one is asymptomatic, no symptoms, right? But the serum uric acid is elevated. And then you have the acute phase. Here you have excruciating pain and inflammation of one or more small joint, especially the great toe, like your picture is showing. And then you have chronic gout, which results from repetitive episode of acute gout, results in the deposit of uric crystals under the skin, within the organs, especially the renal system. Not good. Not good. Next slide. Next slide. So see those uric acid that have deposited in the areas where they shouldn't deposit? All right. Definitely body image disturbance is a big problem here. It's a big problem. It could even deposit in your earlobes, right? So in terms of assessment, we're going to assess for pain in the involved joints, swelling and inflammation of the joint, tophi, which is hard, fairly large, irregular shape deposit in the skin like you're seeing right now, that break open and discharge a yellow, gritty substance. There's low-grade fever, there's malaise and headache, pruritus, itching, presence of renal stones, and elevated uric acid levels. So some of your implementation here is to provide a low purine diet, instruct the client to avoid foods such as organ meats, wine, aged tea, cheese, all those have high purine. Encourage a high fiber intake, increase in fluid, and of course, the fluid to help flush the stone. Encourage weight-bearing diet. Instruct the client to avoid alcohol, starvation diet, because they can precipitate the gout attack. Try to increase your urine pH above 6 by drinking alkaline ash food. So alkaline ash food such as citrus fruits, juices, milk, and other dairy product. Provide bed rest during acute phase. Monitor joint mobility and appearance of joint. The pain is so bad, nothing touches it. So like a cradle to the bed so that the sheets are off the area. Examine the affected leg. Protect the affected limb from excessive movement, like I said, and sheets and blankets. Provide a heat or cold for local treatment. Administration of NSAIDs. So with the acute case, you give NSAIDs and you give, allopurinol. Indomethacin, allopurinol, or colchicine, and then allopurinol for prevention, because some people, their gout is so bad that they put them on prophylaxis as well. Okay, allopurinol, colchicine. So you should look up these drugs. Next slide. And now you have the non-inflammatory joint disease, right? So osteoarthritis. Next slide. So osteoarthritis, also known as degenerative joint disease, right? Causes are known. It can be caused by trauma, fractures, infection, obesity, progressive degeneration of the joint caused by wear and tear. So age is a risk factor. Those who are involved in sports that requires a lot of repetitive joints. Causes the formation of bony buildup and the loss of cartilage. So you have cartilage between the bone. So those cartilage are lost because it's grinding and grinding and grinding, wears out. So now you have bone and bone. So it affects the weight-bearing joints, right, that receive the greatest stress, such as our knees, our toes, and our lower spine. Next slide. So here are some of the no's, Herndon's, Borchet's. You can see how this can affect your activity of daily living. So in terms of assessment, you're assessing joint pain that usually is early in the disease process but diminishes after rest and intensify after activity. As the disease progresses, the pain occurs with slight motion or even at rest. Symptoms are aggravated by temperature change and humidity. There's crepitus, there's joint enlargement, there is Herndon's node, Borchet's node, even forming like bow leg, difficulty getting up from prolonged sitting. There's atrophy of the muscle, inability to perform certain activities, daily living, walking short distances, compression of the spine as manifested by radiating pain, stiffness, and muscle spasm in both or one extremities. For pain, we administer NSAIDs, salicylates, and muscle relaxants. Steroid injections. There are some limitations. After 6 injections, you can't have any more, like to the knee. Immobilize the affected joint with splint and brace. Avoid large pillows under the head or knees. Provide a bed or foot cradle. Position the client prone twice daily. This could really be debilitating condition. Encourage them to have adequate rest and sleep well. Encourage them to have proper diet and weight loss, because that may put pressure. Next slide. So physical mobility is definitely a big deal. So impaired physical mobility would be your nursing diagnosis. So what you as a nurse would do to reinforce the exercise program and the importance of participating in the program. Instructing the client that exercise should be active rather than passive, and to exercise only at the point of pain. Instruct the client to stop exercise if there's pain, and instruct the client to decrease the number of repetitions in an exercise where inflammation is severe. Next slide. So in terms of surgical treatment and osteotomy and total replacement, right? So osteotomy, the bone is cut to correct the joint deformity and promote alignment, versus total joint replacement is performed when all the other measures have been utilized to the maximum. So the steroid injections and so forth. The hips and knees are the most commonly replaced one, and is contraindicated in the presence of someone who has, osteoporosis, severe inflammation, or infection. Next slide. So the teaching for the clients that have rheumatoid arthritis and osteoarthritis, it's very simple, but it's to assist the client to identify and correct any hazards in the home, because this is lifelong. Instruct the client to use correct use of assistive devices. Instruct them on how to conserve their energy. Review any exercise program that they have. Instruct the client to sit in a chair with high, straight back. Instruct the client to use small pillows only when lying down. Instruct the client to measure to protect their joints. Instruct them on how to take their medication that they've been prescribed, and the importance of follow up with the doctor. Next slide. So the metabolic bone diseases are osteoporosis, osteomalacia, and Peyer's disease. Let's talk about each one. Osteoporosis. This is an age-related metabolic disease. And what happens is the bone is demineralized, results in the loss of bone mass, which leads to fragile, porous bones and subsequently fracture. Greater bone reabsorption than the bone formation that occurs. Occurs most commonly in the wrist, the hips, and the vertebrae column. Very dangerous. Can occur post-menopausal or as a result of metabolic disorders or calcium deficiencies. You see the Dowager's hump, right? Kyphosis. It's usually an indication of that. Next slide. So the osteoporotic changes as someone gets older. So they lost their height, right? And so the assessment findings that back pain after lifting, bending, or stooping, back pain that increases with palpation, the pelvic or the hip pain, especially with weight bearing. They may have problems with balance, and you see their height decreases or decline as the vertebrae are being compressed. And then you see kyphosis of the dorsal spine. And then there's constipation, abdominal distension, respiratory impairment as a result of movement restriction and spinal deformity. And then you will see pathologic fractures, and you see an appearance of thin, porous bone when you do an x-ray. Next slide. So this is severe osteoporosis. So these individuals, they have a risk for injury, right? So we must provide a safe and hazard-free environment and assist them to identify hazards in their own environment, home. Use the side wheels to prevent falls, because if they fall, they break. Move the client gently when turning and repositioning, right? Encourage ambulation. Assist with ambulation if the client is unsteady, because you don't want them to fall. Instruct the use of assistive devices such as cane or walker. Provide range of motion exercises. Active, encourage active, provide passive. Instruct the client to use good body mechanics and exercises to strengthen abdominal and back muscles. And instruct the client to avoid activities that can cause vertebral compression. Next slide. We can also apply a back brace as prescribed during acute phase to immobilize the spine and provide spinal column support. It's called a Milwaukee brace. Encourage the use of a firm mattress. Provide a diet high in protein, calcium, vitamin C, and vitamin D, and iron. Encourage adequate fluid intake to prevent renal calculi. And instruct the client to avoid alcohol and coffee. Administer estrogen or androgen to decrease the rate of bone reabsorption as prescribed. And of course, administer calcium, vitamin D, and phosphate as prescribed for bone metabolism. And administer calcitonin as prescribed to inhibit bone loss. Analgesics, muscle relaxant, anti-inflammatory medication is prescribed. Biphosphonates are the drugs that are used to help with bone reabsorption. So biphosphonates, you got to make sure that your person takes it sitting upright, with a full glass of water, because of the irritation or of the esophageal. Next slide. Osteomalacia is another metabolic condition. It's characterized by inadequate and delayed mineralization of compact and spongy bones. So the bone volume is unchanged, but the replaced bone consists of soft bone instead of rigid bone. So soft. In adults, it's called osteomalacia, which is in children, it's called rickets, soft bones. So it's usually rare in the United States and Western Europe. It's usually caused by vitamin D deficiency. Risk factors are dietary deformities, decreased endogenous production, malabsorption, renal tubular diseases, anticonvulsant therapy. Vitamin D normally regulates and enhances the absorption. So lack of vitamin D, it's going to, because if you don't have vitamin D, you're not going to absorb calcium. So therefore, your bone's going to be soft. Next slide. So PSH disease is a chronic bone, condition that generally results in enlarged, deformed bones due to excessive breakdown and formation of the bone tissue that cause bones to weaken. Rarely is diagnosed in people under 40 years of age, but most of it is after 40. The most common symptoms that people complain about is bone pain, headaches, and hearing loss may occur when PSH disease affect the skull. We can do an X-ray, which can show the characteristic appearance on the X-ray. Alkaline, ALKALINE, phosphate test can be done because an elevated level of alkaline phosphates in the blood can suggest PSH disease. Bone scan is usually useful in determining the extent and activity of the condition. The reason why it must be treated is because PSH disease can lead to other things: arthritis, hearing loss, heart disease, kidney stone, sarcoma, other nervous system impairment. So this is why we have to treat it. Similar drugs as osteoporosis. Next slide. So a client that has musculoskeletal conditions, there are some nursing diagnoses. One is knowledge deficit related to the treatment regimen. Acute and chronic pain related to musculoskeletal disorder. Impaired physical mobility related to the musculoskeletal disorders, cast, traction, etc. Self-care deficit, bathing, hygiene, feeding, dressing, grooming, or toileting related to restricted mobility. Risk for infection related to surgical procedure and surgical incision. Anxiety related to health status and traction device. Impaired skin integrity related to laceration and abrasion. Risk for peripheral neurovascular dysfunction. Risk for ineffective therapeutic regimen management related to insufficient knowledge or lack of available support or resources. Risk for situational low self-esteem. Disturbed body image and or functional impairment related to impact of neurovascular disease. Imbalanced nutrition. More than body requirement related to obesity. Risk for ineffective peripheral tissue perfusion related to swelling. And risk for injury. All right, so there's a lot of nursing diagnoses. Next slide. That ends our discussion for this lecture. Thank you. I forgot.